My name is Robert Scully. I'm a GP and a professor of rural medicine here at the University of Galway. And I'm just going to spend a few moments with some opening remarks before we hand over to today's speaker, Professor Derek O'Keefe. Let me just... Great. The Reach Network, as I said, this is our fifth event. I think we've about 100 people registered for today's event, and great to see that our membership is growing month on month. The rationale for this meeting is essentially recognizing that people who work outside of the major cities in Ireland probably have different CPD requirements, and so we're focusing here on clinical generalism and interconnectedness across our networks between disciplines and beyond. And I'm delighted that the membership of this group is so well represented amongst our HSCP colleagues and general practice and hospital-based colleagues as well. So a few housekeeping notes. This is a virtual meeting. Really delighted to keep your cameras on, but certainly if you're asking a question at the end, the meeting will be recorded. Previous sessions are available on our website or YouTube channel, and we'll share that in the chat. Presentation will go on for about 40 minutes, and we'll have an opportunity for questions at the end. And please use the chat function to input questions if you need. Keep your microphone muted, and if you don't, we'll mute it for you. There is CPD available for this event, and the hospital buddy code is 9025, and our ICGP CPD will be forthcoming. We send them in groups, and then we'll contact you by email. We'll update that as well in the chat, because I know people will be joining late and might miss this. And just a disclaimer, obviously the information that's provided today, whilst it's not a clinical topic, it is intended to be as accurate as possible, and the talk is given, the presentation does not replace clinical guidelines and should not be used as such. Just very briefly, next month, you might put a hold in your diary for the 19th of April. Again, it's always the third Thursday in the month. I'm delighted that our colleague, Professor Dara Byrne, who's the HSE clinical lead for simulation and professor of simulation at the University of Galway, will present a talk on simulation to improve and integrate. So really, we're going to explore how simulation is not just around using it for clinical skills provision, but can also affect how health systems are delivered. So really looking forward to that talk, and very relevant for this group. But to today's topic, really delighted to have our colleague, Professor Derek O'Keefe, deliver a talk on digital transformation of rural medicine, engineering the end of distance decay. And this is a really relevant talk for this group. Derek is a consultant physician and endocrinologist here in Galway, but also an engineer, and has a social media tagline, Physicianeer. So he's a hybrid engineer and physician, which is, we certainly need more people like that. And he's Professor of Medical Device Technology here at the University of Galway. And Derek, just so you know, your talk is getting a lot of attention on the Rural Island GP WhatsApp group. So we've got new members today. Really looking forward to this talk. So Derek, we will hand over to you, and thank you again, and looking forward to, I'll stop sharing and you can get going. So thank you.
Great. Okay. So thanks very much, Robert, for the introduction and for the invite to speak today. I want to welcome you all, especially on such a sunny day. I'm sure many of you have the temptation of leaving your office and going outside. So please feel free to do that and listen to this in the background, and hopefully it's of some interest to you. So I'm going to speak about digital transformation of rural medicine, engineering the end of the distance decay. We're going to talk about what that is. And in essence, what we're going to talk about is ending healthcare inequality that exists due to the geography that we share with each other. And the big thing is that distance decay isn't a law of nature. It's something that's a consequence of design, and therefore we can change it. I think that's an important thing to state. As you heard, just for context, for some of you, I haven't met many of you. So I'm a physicianeer, as Robert mentioned. So that's a physician engineer. So I would have trained originally in engineering, electronic engineering, and then computer engineering, and then biomedical. And then I would have been inspired by working in Harvard, doing a postdoc there, by people who had done engineering at MIT and then medicine at Harvard. So they had the dual skill set, because, as you know, engineers are often problem solving, and they're solutions orientated. And anyone who works in clinical medicine knows that it's full of clinical problems. So there's a great kind of opportunity there for innovation when you combine those two skill sets. And I got my job here in Galway in 2018 as an academic consultant. So I split my time between the university and the hospital. and my father cried. He was so happy that I got a permanent job after all that college. So delighted to be here today. And the other thing to say is when I started working in 2018 as a consultant, about a year into it, I realized that there was a massive difference between medicine, which was what I was practicing, and healthcare, which is the way that we practice medicine. So I decided to do an MBA then part-time here at the University of Galway to teach me more about healthcare. And I think that's really important to have those different lenses, which I'm going to talk about now. So hopefully you know what this animal is. This is a male silverback gorilla. And I really enjoy once a year going away on trips to see rare wildlife and to take pictures of them. This animal you can see in East Africa, in Bwindi National Park in Uganda, or a bit south of that in the Virunga Mountain Range in Rwanda. And when you're planning a trip like this for a year with your buddies on WhatsApp groups, um, one of the most important things you do with your planning is your equipment. So when we go on these trips, we take these cameras with us. They're called SLRs. And what they're very specific about is the type of lens that you use. So you can use either a very wide angle lens, a normal lens, or a microscopic lens, or a highly telephoto lens. And depending on which lens you use, you get a different type of picture. So if you're too panned out, you're going to get all the jungle. If you're too zoomed in, you're going to get its left shoulder. So you got to get the lens right to get the right picture. And I think that's important when it comes to healthcare, when you're trying to analyze it to find out what's going wrong with it. The example I use is that if you're in the hospital working as a doctor, sometimes you get called down to the ED. Somebody comes in with a cut on their leg, and you're asked to decide if it's going to go medical or surgical, depending on their comorbidities and what else the presentation has. And you might look at the wound, and as a doctor, as a clinician, you might say, that's a very small wound. We'll just wash it out. We'll put a dressing on it and give them oral antibiotics for a week. And then as an engineer, you're looking at the same problem and you're thinking in your head, I wonder if we could put the antibiotic into the actual dressing. Then they'd only have local effects of the antibiotic. They wouldn't have the systemic side effects of nausea or diarrhea. And then maybe with the MBA lens, you're looking at it saying, why is this person even in the emergency department? Why did they drive 2 hours from Roscommon to come down here to get this reviewed? They should be seen as an urgent care facility. And so the exact same problem with different lenses gives you different insights. And I think when you're trying to solve problems, it's really useful to do that, to actually kind of zoom out of your own biases and try and look at things from different perspectives. So I work here at the University Hospital Galway. As you know, it's a Model 4 hospital here in Galway, 700-bed hospital. I'm a physician. My specialty interest is endocrinology, and most endocrinologists spend 70 to 80% of their time on diabetes. That's the hormone insulin that goes wrong the most. But 20% is thyroid, and then the rest is adrenal, pituitary, and other disorders. And then I've just stepped down as the national lead for diabetes the last 3 years. The reason I put this up here is it gave me an opportunity to get involved with healthcare leadership. So we're all very frustrated in our jobs sometimes. It can feel like a butterfly in treacle, that you can't kind of flap the wings that you want to. And I remember back in 2020, 2021, just being frustrated that so many patients were coming into me with type 1 diabetes and still in 2021 having to prick their finger 5 times a day to get their blood values from the glucometers. I had patients who were sitting outside my waiting room before the clinic, and they were literally writing their blood glucoses into their books in the car before they came in to see me at the clinic. And I remember thinking, it felt for them like coming to the teacher, and therefore they had to have their sugars in the book, that the whole system was wrong. And so, for a couple of weeks there, I kept saying to myself, "Oh, this is so bad that they don't have CGM, which is a technology. It's a device like a €2 size coin that sits in the upper outer arm, and it sends 200 values a day to your phone. So you don't need to be pricking your finger anymore, and you don't need to be remembering to write it down every day when you take your insulin." And I guess I was just frustrated that they didn't have access to that technology, even though at that time it was starting to become widely available internationally. And it didn't make sense to me why they didn't have it, if you understand. Um, and in particular, there was one patient in 2021. He came in, he was an elderly man with Parkinson's with type 1 diabetes. And he told me it was impossible nearly for him to take his blood sugars because his hands were shaking so much for him to actually take it. And it was a bit like that Irish story you hear as a child, where the farmer goes into the field every Sunday morning and he shouts at the sky and says, God, why haven't I won the lotto? There's another Saturday night has passed and I haven't won it. And every Sunday he goes out and shakes his fist at the sky and says, God, why haven't I won the lotto? And eventually God shouts back and says, well, could you at least buy a ticket? So I think that's really important that you need to be engaged in the place that you work with to try and change things. You can't just be a hurler on the ditch. If you don't like the way the team is playing, you got to get involved with coaching and management and try and improve things. So I decided to go forward for national lead. And one of my goals in that period was to get CGM for patients with diabetes. And thankfully, we achieved that. So I think that's an important lesson as well. Just to say as well, I've also been involved with the fantastic work that's going on in the HSE led by Damien McCallan and his group and Colm Henry to try and digitize our health service. So we all know that for many years, digital health in the Irish health system and the UK and other public health systems in Europe has been a manana project. It's something that we'll do tomorrow, something that'll eventually happen. People write reports, they do PowerPoint presentations, and nothing ever happens. But something interesting happened back in 2021, 22, whereby there was the appetite to do this, which we all can agree with because the rest of our lives are digitized. But more importantly, um, the European Union brought out a piece of legislation that said that if EU countries aren't able to share electronic health records by 2030, the EU will fine those countries. So when I read that in the paper, somebody had asked me to join one of these committees, and you're always thinking, is this committee a good use of your time? Will there be an output from it? I was thinking at the time, should I join the committee or not? But when I read that in the paper back in 2021, I remember thinking, wow, this is perfect. No student ever does their homework unless the teacher checks it. And now somebody's going to be checking our homework in 2030. So there's almost like a mandate to get this done. So we had the will, because people wanted to set up these committees and write these strategies. We had an external body going to assess us or audit us, which is very important for oversight. And then the third thing we needed, of course, was money, which makes everything happen. And around that time, you might remember with the multinational corporations and our competitive tax rates, that we actually went to court in the EU with Apple saying that we didn't want to take any more money off Apple tax-wise. And the EU insisted that we took an extra 6 billion off them. And so reluctantly, we took that money off them, and suddenly we had a budget then to do something like this because the budget to put in, just for example, an electronic health record, which is one small part of digital health, is about 1.3 billion. So it's a huge amount of money to put that into all the hospitals in Ireland, all the community centres, and so on. But suddenly we had a budget, we had the clinical and the IT will and the HSE, and we had somebody externally telling us to do it or they'd fine us. So it was the right set of circumstances for this to happen. And these documents are available for you to read. Digital for Care, which is the strategy for the next 6 years or 4 years now. The roadmap for how those things are going to happen, so you can read in detail about when, for example, the EHR is going to come to a hospital near you. Because for many years we've just got on with it and developed local solutions, and it's led to a lot of digital islands around the place where things can't talk to each other. So, I could be in my clinic here in Galway University Hospital. I could have a patient from Port which is 30 minutes out the road, and I may not be able to access their bloods or their radiology. So that they're the kind of issues that we often face all around Ireland, not just in Galway. And so the roadmap will tell you that, for example, the tender has already gone out for the EHR, and then later this year in the autumn, we're going to select a vendor, and then it'll be rolled out over the next 4 years in Ireland, starting in North Dublin next year. So there's a very clear plan of rolling out this technology to improve the digital framework of Ireland. And I just put in that last picture there because that launched last week. This is the HSE and Department of Health's document called AI for Care. So AI is moving from your headlines on your social media feed and your broadsheets into actual practice in Ireland, both clinical practice, operational improvement, public health improvement, and so many other aspects of care. So that's actually a formal document now by our health service. So I'd encourage you to read it to give you some of the granularity behind the talk I'm doing today. So obviously the University of Galway, it's a beautiful campus here since 1845. You can just see Harry Potter there at one of the windows. And I always show this picture to remind people that it's based on Christ Church in Oxford. It's the same design, and it's a beautiful place to work, especially on a day like today. When I started in 2018, I knew a fair bit about engineering and medicine, but I didn't know everything. So I realized really quickly it was important to develop a network or a lab that could find a problem at the bedside, go to the bench to get the solution, and then bring that back to the bedside again. And at the bench, we needed to have input from lots of different specialists. So not just medics, not just engineers, but also, scientists, psychologists, educationalists, and so many subdisciplines of each of those pedagogical areas. So we created the hive with the understanding that not one honeybee can make enough honey to be, meaningful, that you have to collaborate to build things bigger than yourself. And one important lesson I learned in the MBA was the lesson of ideas. So we all have great ideas, and there's a famous saying that the most expensive real estate in any city, so Galway, Dublin, London, Sydney, is the graveyard. And the reason the graveyard is so expensive is because it's full of people with million-dollar ideas in their head. So many people walk around with great ideas, but they never actually action them. And I think if you want to have impact, you need to be able to shorten the decision cycle between idea and actual decision and then action. And the Hive Lab has managed to do that in the last few years because of the people that we've worked with. I wanted to play this short clip for you as well. I think this sums up my entire attitude to innovation. It's one of the best ones I've ever heard talking about innovation, and it's an important lens to use when you're talking about working in clinical practice and how to improve it. It's Steve Jobs of Apple fame between when he first got let go from Apple and when he went back there
So
again.
the thing I would say is when you grow up, you tend to get told that the world is the way it is, and your life is just to live your life inside the world. Try not to bash into the walls too much. Try to have a nice family life. Have fun. Save a little money. Um, but life, that's a very limited life. Life can be much broader once you discover one simple fact, and that is everything around you that you call life was made up by people that were no smarter than you. And you can change it. You can influence it. You can build your own things that other people can use. And the minute that you understand that you can poke life and actually something will, if you push in, something will pop out the other side, that you can change it, you can mold it. That's maybe the most important thing, is to shake off this erroneous notion that life is there and you're just going to live in it, versus embrace it, change it, improve it, make your mark upon it. I think that's very important. And however you learn that, once you learn it, you'll want to change life and make it better, because it's kind of messed up in a lot of ways. Once you learn that, you'll never be the same again.
Okay, and so on that theme, then, Archbishop Desmond Tutu, who the University of Galway gave an honorary doctorate to about 20 years ago, he also famously said there comes a point when you need to stop pulling people out of rivers and go upstream to find out why they're falling in. And again, it's that kind of mindset of just kind of stepping back, you know, figuring out what you're doing and is it the most efficient way you're doing it? And if it's not the most efficient way, to change it. And I think, again, that's a big overarching theme of this talk and the work that we do in the Hive Lab. When I started in 2018 as a consultant in the hospital, I was diagnosed with a fatal disease called new consultantitis. And that's essentially when I went in and I thought, you know what, all these people are idiots. I'll just go in and I'll just change that one thing and I'll be able to fix the problem that I'm seeing every day in the hospital as a registrar or as a SHO or an intern. And then, of course, when you get into it as a consultant, you realize actually healthcare is extremely complex. And by you moving a resource somewhere, it might, unintentionally affect something somewhere else. And therefore, you really have to have a 360-degree understanding of the health system if you're going to try and affect change. There's no point shouting over here that you need resources if those resources that come to you affect another part of the health system that's maybe more acute or more needing of that resource. And so you need to appreciate that when you're trying to change the machine. The other thing you need to have for sure, all of us need to have it in life, is high agency. So these are two people with the same problems. They both are stranded on a desert island. They both have a certain scope of control. One of them just sits there and says, I have problems. I'm just going to wait till someone comes and helps me, and probably dies on the island. And the other person looks around and says, well, what can I change? How can I influence my outcome here by using what I have around me? And I think that's a really important lesson to learn, both in your personal life, but in your professional life, that you have a certain amount of agency. So you may not be able to control the geopolitical situation in the Gulf at the moment, but you can certainly control things around you in your scope of control. in your job. So when people come to me at our lab meetings, for example, and they have a problem, I always insist on them telling me the solution first. So I say to them, okay, thanks for bringing that to my attention. How would you fix this? And if they haven't thought about that, I tell them to go away and come back and think about it, so that they have put some thought into how you might solve this based on their situation or their resources. And that principle is called agency. It's something you learn. And actually, in a world now of universal knowledge, so we all have the ability to go onto a large language model right now and type in any question and get detailed protocols, proposals, anything you want from a large language model. So, like Transition student now can generate, a European Union project using the right prompts and skip the whole college thing. And so the only thing that's separating you from people with equal access to knowledge then is agency. So what are you going to do with that knowledge? How are you going to take action with it? And I think that's something that universities are going to have to deal with in the next few years as they try and find value in the information or knowledge ecosystem. So the way you know, by the way, just in your own life, who is somebody that you know that has high agency, hopefully it's you. But if you got stuck in a Siberian prison, wrongly accused of a crime, and you're behind 6 foot walls in the middle of nowhere, who would be the person if you could make one phone call that you would ring to help you in that situation? And that's usually the person in your life with the highest agency. So think about that. What characteristics do they have that if you break down at the side of a road, or you're having a problem at work, or you're having a problem in a Siberian prison, that they'd be the person you'd call? And their skill set is the skill set of high agency and something you should try and emulate. Most problems in healthcare are very, very complex. You might just see a car up front, but then when you go to disassemble it, you realize actually there's a lot of parts. And therefore, you know, lots of people are smart, lots of people have good ideas, but what you need is the agency then to actually act on those ideas to improve things. And these are some of the people that I'm speaking about that have worked with our Hive lab now in the last 7 years or so to build some interesting projects, from drones to robots to digital health and digital stents. Okay, so I put this picture up just to again give you an appreciation of where we're living and working, and we've all seen this map so many times. But a different lens on this map. This map isn't the rivers, it isn't the mountains, it isn't the urban areas. It's actually a map of the population density. And again, you might not think of that intuitively, but one of the reasons that we live in the west of Ireland is it's just beautiful here, right? It's rugged countryside. You can drive for miles without meeting another soul, and you can just, drink in nature. But that's also a problem then when it comes to access to resources, as we're going to talk about. So, just for example, Galway City has a population density of about 40 people per square kilometre. Galway County is about 20 people per square kilometre. And then some parts of Mayo, it can be 10 people per square kilometre, and the islands, similarly enough. Whereas Dublin, for example, has a population density of about 5,000 people per square kilometre. So much higher density than Galway. London has a population density of about 10,000 per square kilometre. And then when you look to the Asian cities like Shanghai and Singapore, they have population densities of around 20,000 people per square kilometre. And that has a significant impact in your ability to access services. And it's not that something you might think about when you're doing your clinic, but it's something that's very important when you're coming to design equal healthcare for everybody. So in my own training over the years, I would have worked in West Africa, in Ghana, where a lot of my patients had to walk miles to see a primary care doctor or visit a hospital. I've worked in New Ireland, in Papua New Guinea, again, a very remote part of the world where if we didn't have specialist opinions or expertise at the hospital, if we didn't have access to dialysis, for example, the patient would die if they needed dialysis because there just wasn't access to it. And that's a big problem the more rural you live. And we don't often think of where we live in the world as rural compared to those parts of the world, but we actually do have a disadvantage in some of the geographic landscapes of Western Europe. And you're thinking there of Western Ireland, the Western Scottish countryside, the islands, obviously, off Scotland, Norway, and so on, and Iceland. So the underpinning of this talk today, one of the reasons why I was invited to speak is that back in 2021, we decided to do a digital health project to improve care to people who live on the islands off the west coast of Ireland. And we started that project with Research Ireland funding over about 2 years on Clare Island, a beautiful island of about 150 people in Clew Bay off the coast of Mayo. And that project went very well. And because it went well, we then put the project forward for consideration for a funding or a grant from the HSE inside the castle, as it were, through their Sláintecare Innovation Integration Fund, or SIF funding. And so we put that in and it got selected. And that allowed us to take what we had learnt on the original island rollout and expand it to 3 islands. So we did Clare Island, Inishturk, and Inishbofin. Um, and then that went through a 2-year cycle of evaluation. And in that project, we had really good clinical champions like Dr. Noreen Curtis, the GP who supports those islands, Dr. Marco Mali. So really good clinical champions who helped us to try out new ways of working. So famously, we're currently on the 47th president of the United States. And so 20 presidents ago, the 27th president of the United States was a gentleman called Woodrow Wilson, famous because he was the only president who had a PhD in the 47 presidents. But he also famously said, if you want to make enemies, try and change things. Because people are kind of usually stuck in their ways and their patterns, and they don't like changing things. So when you're trying to do something like this that's different and innovative, it's very important to identify champions, both in the technical side and on the clinical side. And so with Noreen and Mark, I'm delighted to say they were very supportive of this project early on. And indeed, also our colleagues in the ECC hubs, who are the new, as you know, from Sláintecare, the community hub between the hospital and the primary care and the patient. So we had people like the ICPOT team with Dr. Michelle Canavan, who spoke at the last REACH meeting, Dr. Maria Costello, and then, of course, Dr. Sinead Walsh in COPD, and the brilliant Dr. Susan Connolly in cardiology, and Naria Fareh. So we've had some really good champions to make this happen, and I think that's very important as well to say up front. So we did it for the 2 years, and we found out last year, then just in December, at the end of the review of all these SIF projects nationally, that our SIF project had been selected to be the one to be rolled out nationally. So now that's fantastic, because that means now that for the next 2 years, we're entering in a period to take what we learnt on one island and it did a pathfinder to 3 islands and expand it to all 12 islands off the west coast of Ireland. And I think that's a great testament to the hard work that's been done by the team over the last 5 years or so, that those patients on those islands will be able to access part of their healthcare remotely. And I think that's just a really important thing to highlight as a success, because not everything in life is a success. So that's a good thing. So the central thesis of this talk is that distance decay is real, measurable, and causing harm, and we're going to speak about that. That digital transformation, as I've outlined to you, can collapse it, but only if you engineer it right. And that's important, again, the idea of 360-degree looking at it. And the most important thing is the responsibility to design that system sits with us. So you can't just sit there on the island asking for help. You've got to actually stand up and try and change things yourself. And as I said, not everything will work, but failure is not fatal. You just keep going, come up with a new idea or a revision of your original idea. So the idea of distance as injustice is not something people think about very often, but as I mentioned with my own examples in West Africa and Asia, and indeed the west of Ireland, it's very common for me to be at my endocrinology clinic and have patients driving 2, 3, 4 hours to Galway, as far away as Letterkenny. They come for specialist opinion. So they might come down to me from Letterkenny, they're driving 4 or 5 hours, or they're coming from the islands, they're getting a ferry, they're driving for 2 or 3 hours, they're parking in the hospital if they can get it for an hour, they're sitting in a waiting room for 2 hours to talk to a specialist like myself for 10 minutes. So that's a problem, right? That's just a problem in the whole way the system is designed. And back in 2019, I did a TED talk. It's on YouTube. It's called Digital Doctors, and it explains a very simple idea that if we can digitize banking, like if I was to ask you, when was the last time you went into a physical bank? It was probably a long time ago to sign a mortgage or something like that. You know, most of our banking is done online now, and they've developed the technology and the encryption to make us comfortable that we can manage our money, one of our most important assets besides health, digitally. So why hasn't healthcare caught up? And that's the whole thesis of what we're talking about today, because it does actually improve healthcare outcomes. So we were recently invited down to Western Australia, because that's the other thing to remember. Of course, this is not unique to Ireland. There's many parts of the world, as we talked about, that have huge geographic areas and trying to provide care to those people. So we were invited down to Western Australia in Perth in early February, because they wanted to teach and learn. They wanted to learn what we were hoping to do in the west of Ireland, what lessons we had learned, and what we were hoping to do going forward. And equally, they wanted to share with us. So for those who haven't seen a map like this, the Western Australia is that left-hand part of the map, and they have a geographic area about 40 times the size of Ireland. And so Perth in the bottom left there is a population of about 1 million people live in that city. And then outside of that, then the other population is just extremely remote. And they would have championed over the years the service you might have seen as a kid on television, flying doctors, where you fly a doctor in, get somebody, scoop them, and bring them back. And the problem is that's not a very scalable solution really because you can't be sending airplanes everywhere. So they're trying to lean in now to the digital part of managing people's health remotely, especially as we should point out that people are living longer. So if you open a medical chart in a hospital, it's very common to open a chart for a 74-year-old patient and you look at it and you see that, oh yeah, when they were 58, they had a heart attack, but they got a stent. And then when they were 66, they got prostate cancer, but they got surgery. And then when they were 71, they fell and they broke their hip, but then they got a hip replacement. And now they're in front of you at 75 because they have diabetes and their sugar is out of control or something like that. So you can see there was periods there in their medical history where 50 years ago they would have died at that point because that care didn't exist. Whereas now we're doing such a good job in modern medicine, especially in the Western world where we can access it in most cases, that people are living longer. But because they're living longer, so the life expectancy in Ireland now is the mid 80s, so maybe 84. Just out of interest, in Papua New Guinea in 2026, it's still 50. So it depends an awful lot about where you live geography wise. But in the west of Ireland, you're looking at about 80 to 84 for the average human. And because people are living about 15, 20 years beyond their retirement age, we have this tsunami now of chronic disease, whereby we have COPD, diabetes, and heart failure in numbers that we just didn't have 30 years ago. So the waiting room of my outpatient department here at the University Hospital has 25 seats, and my clinics regularly have 50 patients because the clinic was built at a time when we just didn't have as many people living beyond 70. So that's something we have to grapple with as well in healthcare, is that healthcare, it has always been designed to be hospital first. And you certainly should be in a hospital if you have an acute emergency. So if you've had a heart attack, you've had compound fracture, or you have a PE. But actually, when patients come into hospital because of deterioration of heart failure, COPD, or diabetes, you can actually look at that as a failure of chronic disease management because chronic disease needs chronic management. The challenge is that we're treating it with the tip of the spear in the hospital as opposed to treating it when the patient is at home in the community. And there really has been a fantastic effort in Ireland to try and change the lens back towards shift left to the community and to the patient's house through the Sláintecare cross-party agreement and the work that's been put in and the resources that have been put in to things like the hubs that I mentioned earlier, the €500 million in funding for new staff and resources in the community. Because that's where we should be managing patients, not at the tip of the spear in the hospital. And so digital health feeds into that, obviously, because you are trying to manage chronic disease remotely for these populations. So just that typical island patient that I mentioned, she might live 3 kilometers from the mainland, but she's really 40 years from the healthcare system. She has to get a ferry, a bus, and a half day's travel to bring her down to see a specialist. Um, and why is she doing all that? I mean, especially in the world, as I said, of internet banking. So she's doing all that because we haven't actually laid the railway tracks for the digital health infrastructure that's needed. And it's not even the technology, it's the clinical pathways. And it's the buy-in from the clinicians to say, yeah, this should be the default that we give people, virtual first. And I think that's an important thing to remember as well. A lot of the blame isn't the technology, it's the people who are just doing the day job, not embracing or asking for this. And so it's about changing the design of how we actually implement healthcare, which is a much bigger thing than the way you necessarily run your own clinic and so on. You're looking to change the whole thing. So people have looked at this, they've looked at this idea of distance decay, and it turns out that when you do live in a rural part of the world, and this would be intuitive, that you do have less utilization of healthcare resources. So 84% of studies in this scoping review showed that distance decay is a real thing. So the further away you live from a healthcare resource, the less you use it, the less you interact with it because it's far away. And actually, it's not even a kilometer issue, it's actually a time issue. So if you're 30 minutes travel time away from a healthcare resource, you'll use it less. And ultimately, unless it's an acute emergency and the impetus is there for you to go in a blue light ambulance, if you're interacting with your chronic disease appointments, for example, less, because you're saying, oh, that's too much hassle to go to that diabetes clinic or that COPD clinic or that heart failure clinic or CKD clinic. If you're just saying it's too far away, it's too much hassle, and you're not going to them, that's a problem then because you're going to crash into the ED in a blue light ambulance and cause all the trauma to yourself as a person. and then all the resources that are needed in the ED to manage you and get you back to good health and get you, maybe a 1 week hospitalization where you do also have the increased chance of nosocomial infections. I'd say everyone here who's worked clinically in a hospital knows many patients that have come in with COPD and ended up getting novavirus or C. difficile or something else and ended up dying with that and not the disease that they came in with. So we have to be very conscious of that we have to try and avoid hospitalizations. So that's very interesting because that 30-minute window could actually be in an urban area if the traffic is bad enough. All of us who live in Galway, we schedule about an hour to get home in the evening after the hospital because it takes that long. And you can imagine that might affect your willingness to go and engage with your health service, be that your primary care doctor, your hub, or your hospital. So it's a known geographical term, distance decay. It's the observed phenomenon by which the probability of a person accessing healthcare decreases as travel time or geographic distance increases, regardless of the need. And there's a nice graph here, you can see it from that paper, which shows that when you get to about 30 to 45 minutes travel time, your usage drops to 50%. And I mean, that's really profound when you think about it, that you just literally say, you know what, it's okay, I'll just deal with this high sugar, or I'll deal with my breathlessness as best I can, or I'll muddy on. And that's what we're trying to change here. Um, so it is very positive that the distance, the geographic distance, does play a part in people's health. And that's true not only in Ireland, but in Western Australia, in large parts of the United States, and so on. And specifically, things like specialist care is a problem because you normally have to travel to a Model 4 hospital or something like that to get specialist care, or a Model 3 hospital. So if there was a way to collapse that, it would change people's health outcomes. And this brings us back to what we all learned in medical school, the inverse care law, which is an ironic perversion that the availability of good medical care tends to vary inversely with the need for it in the population. So famously, people who have, low socioeconomic class or deprivation, ironically, even though they might need more care, they don't access it as much. And that prompts this new inverse digital care law, which ironically also because you're in a rural area, you might also be underserved because, it's rural, you have elderly populations and they're underserved maybe from a technology point of view. So it's like a double jeopardy if you live rurally. If you're socioeconomically deprived and you're rural, you might have problems with accessing technology to get that digital health. So what we're talking about is engineering the collapse of distance. So is there technology out there that allows you to be present while you're remote, if that makes sense? And of course there is. We just talked about banking there and so on. So we're not just digitizing healthcare, we're actually redistributing it across space and time. Because if you want to provide care to a patient like me at my clinic, we have to be co-located, right? So I have to see the patient so that I can provide care to them. There has to be synchrony, so I have to be able to see their data. So patients, as I said, famously open up blood sugar books and show them to me, or maybe weights if it's for heart failure. And then there has to be specialist opinion. So I have to have the bandwidth to see all those patients. So if I see 50 patients in a clinic and, I have a waiting list of 2,000 people, it's only so many 50s I can get into that 2,000 people. So there has to be the expertise there, the volume of it. And so technology is starting to show us that we can address these three things that you need, and collapse that distance decay. So telehealth obviously removes the need to travel. Remote monitoring of patients through that CGM and other technology removes the synchrony dependence. And then AI, as I mentioned with the AI for Care plan, is starting to show us the potential for AI to provide specialist care. Now, I need to put an asterisk there, right? Because the famous thing is AI is going to take all the medical jobs. And that's not true, right? Because the truth is it's going to do some of our tasks, but your job is way more than one task. And if it isn't, you're not doing a very complex job. So we recently did a project in the hospital here where we got an AI avatar that we developed to explain to patients about their medical condition or about their medicines. And it turns out when we did it that the patients enjoyed and learned as much from the AI avatar as they did from the nurse or from me as the doctor. And does that make the nurse or me upset? Absolutely not, because we have 1,000 jobs to do every week. So if the AI can do it as good as us or support us in doing it, so we don't have to do a 15-minute appointment for education, we can do a 10-minute appointment, and then two of them together can be another 10-minute face-to-face appointment. That's efficiency, and that's what we're using AI for, just like you would use the internet to look up to date or something like that. So the tool of AI has been kind of maligned in the general press, but it actually has a lot of potential. I would also say, just to point out, the FDA, the regulatory agency in America, in the last 7 years, it's approved literally 3,000 pieces of software or hardware for medical care. Of those 3,000 pieces of hardware or software that's been approved by the FDA because they had the trials done, only 2 of them can make medical decisions. And those 2 devices are the exact same. They're both retinal scanners where you look into a camera, like looking into a Pringles tube. It takes a picture of your retina and then it decides at the end of it, yes, you have diabetic retinal disease. You need to go see an ophthalmologist for specialist care. They're the only, and the other one is the same, just different algorithm. So they're the only things that have been allowed to make a medical decision in healthcare in 7 years. The other 2,998 software and devices are all aids to clinical decisions. And the best example, 80% of them are radiology. So you have a radiologist sitting down looking at a mammogram, sees the mammogram in front of them, then they push a button, they get this second chair opinion that highlights red dots around the mammogram, and then the radiologist clicks on each of them and says benign, 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 benign. Or maybe it spots that one of them is actually maybe suspicious. And that's what it's been used for so far, is as a tool to help somebody make a medical decision. And I think that's important to show the practical data that's out there as opposed to all the hype in the media and all the doomsaying. Okay, so we said that telehealth and virtual care reduces the need to travel. That's really important. So telehealth, tele-EMS, tele-ED. When we were in Australia, they were showing us their tele-ICUs, whereby a Model 4 hospital would have ICU consultants looking after their own Model 4 hospital, but also providing remote care to Model 3 and Model 2 hospitals across West Australia, which wouldn't necessarily have the consultant specialist anaesthetist. They might have nurse providers or RMOs, like registered medical officers at those facilities, and they're getting opinions from the ICU consultant in the Model 4 hospital about what medicines to administer or how to move the patient in the bed or change the ventilator settings and so on. So that model of care is already established in parts of the world, such as the US and in Australia. And what's interesting is that they are actually synchronizing their licensure and their timing with the antipodal part of the world. So there's a lot of consultants in Ireland here, for example, or doctors who are providing telehealth opinions to ICUs and hospitals in Australia in the middle of the day here, which is the middle of the night there. And again, that's just a great example of the global need to zoom out and try and synchronize care around the world with telehealth. So tele-EMS, tele-ED, and virtual ICU, they're all established ways of providing care to rural populations and being smart about things like your time zone and your licensure. So detecting earlier, so we did this really interesting project with Dr. Sinead Walsh and Dr. Susan Connolly, whereby we said, you know what, there's probably a cohort of patients who are high users of our hospital here in Galway. And so, for example, in COPD, there might be 50 patients or so that come in more than 2 weeks a year. So we looked at some of those patients and we said, okay, here's a patient, for example, that came in 20 weeks last year. So they come in for a week under me under general medicine, and then they get better, and then they go home again, and 3 weeks later they come in under somebody else, and then they go home again, and you don't even realize it over the year that person's in 5, 6, 7 times for a week or two each time. So is there a new way of doing that rather than just reactive healthcare? Rather than just pulling that person out of the river, can we go upstream to figure out what's going on? And so we did a project called Virtual Hospital for the last 2 years. And with our clinical champions, as I said, in the consultant leadership, we were able to put devices on people's fingers. So a $20 device, an SpO2 monitor on a patient at home with COPD. And then we were able to monitor them. And if they started to go from from green to amber to red, then one of the clinical teams, such as Emma, one of the nurse specialists, she was able to contact the patient then and adjust their medicines or adjust their inhaler to keep them on the right track. So that kept that patient out of a hospital. So, for example, Dr. Walsh's team now has saved 1,000 bed days in a year using this kind of approach to, work with GPs in the community to maybe identify somebody who's starting to go off, put them on a course of, antibiotics and steroids and monitor them with the virtual care umbrella, and then prevent that hospitalization, that blue light ambulance that's going to happen in a week if they're not intervened with. So that's been very successful, and hopefully it's going to get rolled out nationwide now as the RPM vendors get selected. So chronic disease control is a perfect example for this kind of care. And the pillar 3, as I mentioned, is about AI, as I mentioned, both operationally and as well clinically, that as AI starts to mature and get tested robustly as it should be, we're going to see more of it in the next 5 years ahead of us helping to make decisions. So for example, when I did my clinic yesterday and I had 50 patients, there was about 10 of them at the clinic who I had given 1 year appointments to a year ago. And then they came yesterday and everything was still fine with their diabetes. And we sat there and we talked for 5 minutes about Liverpool Football Club because their diabetes was fine. And it would have been much more useful if those 10 appointments had been given to somebody who needed to see me. So the idea then of using dynamic triage, or working with Medtronic, for example, in diabetes, that your patients will be scheduled based on their clinical needs. So if they've got very bad dysglycemia, they get higher appointments in your system. And so that's the kind of thing that's coming down the line first. And so what we want to do is move the resources, not the patients, and try and decentralize medicine, which has been very centralized for 2000 years. So mobile clinics, ECC hubs, drone delivery. We've done a lot of work with medicine delivery, and then virtual wards, as I talked about. And the idea is when you combine all those things together, you have a new way of providing healthcare to people. Telehealth, RPM, AI, and then the logistics, so you can deliver medicine remotely. People don't have to come into pharmacies and so on. And so we've done these projects in the last 7 years. We've done the virtual care pathways. We've done drone delivery. We're building a very interesting medical device product called a DigiStent. So all stents, as you know, are just metal tubes. So we have this idea now, and we're 2 years into a €6 million project to develop a stent that's digital. So it'll actually tell you and your cardiologist or your vascular surgeon that your stent is starting to maybe clot or it's starting to leak, weeks and months before you actually get the clinical symptoms. So people can come in and then actually get it replaced before the acute clinical issue. And then the question then is, why hasn't this happened? It's not technology, it's the system design. And a big problem with all of this is what's called the implementation gap, where there's a problem between the idea and the actual implementation. And a big part of the project in the next 2 years we're going to do with the islands is trying to address that implementation gap. If you want to go away and read about the tricorder study that came out last month in the NHS, where they used AI stethoscopes to improve cardiac disease recognition in primary care, the result of the trial with hundreds of thousands of patients was negative. When they actually did use the actual AI stethoscope, it was brilliant. It identified 3 times as many cardiac diseases not using it. But the problem is that nobody used it in the trial because it wasn't actually properly put into the workflows. And so that's a really important thing when you're trying to roll out new technology. Digital divide is at the back of our head always. We're always thinking about, can our patients access the technology? We mentioned about the rural inverse digital care law. So we've been working closely with other government agencies such as OGCIO and the National Broadband of Ireland rollout to make sure that the islands will have broadband connection, will be able to take part in this digitized care. And then structural frictions, just in general, when you have cultural resistance of physicians who are used to seeing people face to face in clinic, just saying, I'll just see them at clinic. And maybe they won't be as open to doing it remotely. So we have to change that culture as well, because that's really important. So connectivity gaps, affordability barriers, digital literacy, these are all the things we're trying to fix and integrate into our project, as well as the technology, to make sure we don't miss that implementation gap. The big one being cultural resistance. And that's why it's so important to have clinical champions in primary care, in the hubs, in the hospitals, to make virtual first appointments the default. I think that's really important, because we're going to have to actually consciously change the way we deliver care. It's not, very exciting technology. We're not building rockets to Mars here, but it's simple technology, but the implementation of it is complex. And that's what the goal is here. So we want remote first pathways. We want asynchronous by default, which means remote patient monitoring. And we want the idea that it's integrated seamlessly with your traditional face-to-face, because it won't be for everybody, right? But the volume is so big of chronic disease patients that even if you get 50% of patients seen remotely, that really frees up, for example, the clinical appointments face-to-face in the hospital. And I said, it's just the right time to do this. We have the connectivity with the National Broadband Plan, reaching all the islands by the end of this year. We know that telehealth and RPM are proven clinically successful, especially after COVID. I mentioned to you about policy, both the EU and national policy, and then the AI now is actually being adopted into clinical practice. So that island patient that I spoke to you earlier about, everything has changed on the left to the right because we've taken the action of doing what we're doing by putting in the digital infrastructure and the clinical pathways to do it. And I guess just the last slide really is just a call to action to everybody, because everyone always thinks it's someone else's job to do this. That's the classic thing. Sure, that's not my job. But actually, we all have a part to play in it. So the clinicians have a job to actually adopt this technology and to use it and to try and improve, as I hope they do, the outcomes for their patients. The engineers have to understand the complexities of the hospital system. The policymakers have to show us the roadmap and put the funding in there. And then the leaders, as I said, have to actually make this a priority from all the things that they're trying to do in healthcare. And we'll just finish with this. This is Chris, is one of our patients on the island. He doesn't mind me sharing this picture because he did a documentary for us about this. But Chris tells a story that when he was 6 or 7 years of age on Clare Island, if he wanted to communicate with the mainland, his mother would make him go out to the front of the house there, get some hay and burn it, and the smoke signal would tell the mainland to send a boat out. And then when he was in his teenage years, he got telephone on the island. Then 10 years later, they got radio on the island, then TV, and ultimately internet. And now he has a 5G connectivity on the island to see his specialist in the hospital. So in the space of 94 years, one human lifetime, we've taken that arc of information technology, which is remarkable. So distance decay is not a law of nature. It's a consequence of how we originally set up the whole hospital first healthcare system. And it's something we can change, and we have agency to do that. So thank you very much.
Thanks very much, Derek. That was a really interesting overview and kind of a lens into the future. So thank you. I invite any questions, please.
Yes, please. Can I ask a question?
Please, Jerry. Yeah.
Thank you very much indeed. Professor, you are absolutely a revelation, and you are an inspiration. You're everything. You're like the best thing since sliced bread, and that's not maybe.
Thanks. You might want to speak to my wife. Yeah.
You've done amazing work on the islands, and Dr. Noreen is our colleague, and Dr. Mark as well. But my big question for you is, when are we going to get that service for units such as we have in Mulranny here, where the overwhelming majority of admissions to Mayo University Hospital are 75 plus, overwhelming majority. And we could save so many admissions if we had some virtual link up with the likes of yourself or with geriatricians who could give us the thumbs up on what we do. I believe we could overwhelmingly decongest the A&Es. There is an issue with rural doctors not being able to stay in their own areas. My belief is that there is an amazing mission there for rural doctors to support older people to age in place. I think, as you said yourself, you so cleverly described it, the system is designed for another age when consultants were not available, when they were in their ivory towers. Things have changed, and what you have done with the islands is inspirational, but we do need that in Mulranny, and we need it yesterday.
So, Jerry, I'll be happy to work with you because we do have a plan for that, which is good news. So you're exactly on the ball. So the plan is we're doing the islands first because the idea, it's like Project New York, we called it the first few months. If you can make it there, you can make it anywhere, right? So we're doing it on the islands because it's the most difficult one. But we've actually been greenlit to do a project now starting in September in kind of synchrony with it for the next geographic population that can't access healthcare, and that's the prisons. So I have guys coming into me here in the clinic, and they have a prisoner and they have 3 prison officers, which is an absolute waste of resources for everybody. And the prisoner feels embarrassed to be there, and therefore he doesn't come to his appointments and so on. So we're going to do the prisons next for the next 18 months. And then the one after that, then, Jerry, in our timeline plan is to do what you said there. So the remote centres like Mulranny, and then the nursing homes. Because again, it's bananas to me, and I'm sure every doctor, why a nursing home patient has to come in all that journey to see me, and they usually don't then, and their care suffers. So we do have a plan, and I have to give credit to Colm Henry and Damien McCallion for supporting us in this vision, and indeed the clinical consultants who have kind of, Michelle there with the ICPOP has already kind of championed this. So you're going to see a lot more of this, Jerry. I'd say by 2030, it'll be a different health system, which is fantastic for all of us.
Fantastic. And even already, and thank you for that, and that is fantastic news. ICPOP, I've been trying to link up with ICPOP because what ICPOP are doing is the same as trying to promote aging in place, and that's really what we want to do. And my belief is that rural doctors, I think there's a great case for even employing a second doctor in an area, and who more than make common sense, pay for it in every sense of the word, because the work that could be done in keeping people out of hospital where they don't want to be, as you say yourself, they don't want to pick up MRSA or whatever else is on the agenda there, VRE or whatever. They want to stay in their own area. And the guarantee we give to people locally is that no matter how old or disabled you are, you can stay locally if that's your wish, because nobody wants to go to that big institution there. And you have the key to open it up. And as you say, the nursing homes, there's no chronic care available in nursing homes. The system, the clinical responsibility for nursing homes, there is nobody's responsible. So that whole area is just wide open to be opened up by what you are proposing there. Thank you so much.
Thanks, Jerry. Thanks. Just got mindful of time. We have two questions, please. Michelle, do you want to jump in there?
I just might come in on that because Kate might have a different question, but just on the whole nursing home piece, there is a lot of work underway actually, Jerry, around the clinical program for older persons and actual nursing home care. And within that, the idea of maybe channeling some of the ICPOP resource and expertise into virtual pathways and support the nursing homes that way. But there's a lot going on there, a lot of little pilot projects. But it's like Derek said, like we can do all these pilot projects, but we need to be able to do them on scale so that everyone gets equity of access, you know. And that's been one of our biggest challenges, but just wanted to make that point.
And thanks, Michelle. I know yourself and Robert are very involved in that, and definitely the sooner the better. And thank you so much.
Thanks, Jerry. Thanks, Michelle. Kate?
I just wanted to highlight, in 2016, I went over to rural Canada and worked literally in the back of beyond there after doing clinics in Inishbofin, which I'd say was similar. How we managed MIs there was literally WhatsApping video call, looking at the patient, looking at the vitals, and then getting air transport. The nearest cardiac centre was 2.5 hours by road, so half an hour by light flight, which was an excellent system and worked. But 2 weeks ago, I had an inferior MI come into Lettermore Health Centre, which about 50 minutes by road from Galway, but by WhatsApp videoing the reg on call, we decided how we'd transport in and got him to Needle within 50 minutes, which I think is incredible. So good news, but more to do.
Very good. Great story, yeah.
Thanks very much, Kate. Guys, we on the Reach Network, as you know, we always finish on time, so I'm going to wrap it up there. Derek, just to say thanks very much again for an excellent talk. Lots of comments. Sorry, Miriam, we won't get to you, but that's a nice comment. And we look forward to seeing everybody at the next meeting on the 19th of April. So have a great afternoon. Cheers.